Welcome everyone. I am Trisha Paul. मैं आज लाई हूँ another episode of Breaking the Myths. यहाँ पे हम लोग बात करेंगे with various topics including what is neurosurgery, क्या misconceptions है surgeons के बारे में, what is sleep disc, with also we would be speaking about क्या होता है आपका ब्रेन बाईपास सर्जरी एंडोस्कोप किस ब्रेन सर्जरीज में लगते हैं क्या उसका यूसेज है एंड लास्टली वी वुड बी आल्सो स्पीकिंग अबाउट क्यों सब पेशेंट्स फैमिली मेंबर्स रिलेटिव्स विजिट करते हैं साउथ इंडिया क्यों नहीं कोलकाता जहाँ पे कॉस्टिंग भी सेम है और ये सब बात करने मेरे साथ आ रहे हैं डॉक्टर अरिजीत चक्रवर्ती ही इज टूडेज गेस्ट ऑफ माइन ही इज द कंसल्टेंट न्यूरोसर्जन Manipal Hospitals, Broadway. He was previously attached with Manipal Hospitals, Bangalore as well. With that, let's start this episode unfolding myths and facts. Hello, Dr.
Hello.
Chakravarti. आपसे पूछना है मेरा फर्स्ट क्वेश्चन एंड आई एम वेरी क्यूरियस टू आस्क दिस कि अभी तो आप न्यूरोसर्जन बन चुके हैं ऑलरेडी यू आर स्पेशलाइज्ड इन ब्रेन एंड स्पाइन सर्जरी जब आप चाइल्डहुड डेज में थे स्कूलिंग डेज में आपको क्या तभी भी न्यूरोसर्जन ही बनना था रोज सर्जरीज करने थे या कुछ और बनना था
Very interesting question. Thank you, Trisha, for asking this. But ऐसा है कि childhood में my goal was totally different. I never thought of becoming a doctor itself. Okay, so whatever. So
so what did you want to be
I was more inclined towards probably scientific field or engineering or whatever. I'm not exactly sure, but never thought of becoming a doctor until my 12th grade. Then whatever that for different reasons, my personal interest, it has happened that I came into the MBBS course and everything went well. Then again, my primary goal and intention was to become a physician, more specifically probably neurological medicine or the cardiology was of my interest. For example, I was too much into neurology, the physiology and anatomy, the details of neurology. I used to love it. Then, but again, never thought of becoming a surgeon. Then, gradually, the surgical interest developed, particularly when I was in my internship. Then I asked myself, okay, one thing is very clear that you want to do something with your hands, surgical field, and you already have so much interest in neurology, medicine part of it. So why don't you become a neurosurgeon? So it has both, the surgery as well as medicine. A neurosurgeon has to take care of both the medical part and the surgical part.
yes true
And particular one or two movies neurosurgery oriented, it motivated me further. So final thing happened and came into the neurosurgery residency. So today neurosurgeon. So yeah, that's how it happened.
our world need a good neurosurgeon by the way thank you for becoming one with that as like neurosurgery with the AI and with lots of benefits that we are getting round the clock like what is your way of telling us like let's say about a 20 years of taking a consecutive 20 years like 10 decades back now as a present and the future how would you describe the neurosurgery or the surgeons how they take care of patients the facility is way out
Well, neurosurgery today is very advanced. Now, starting with the neurosurgery that was probably 100 years ago or 50 years ago, so we did not have advanced technologies. The
right
primary goal was to save the life. When a live patient after a neurosurgical procedure was a big thing back then. So then gradually things happened. The neuromicroscope came into the picture, endoscope came into the picture, microscopic neurosurgery started, and with that, they started another world of for neurosurgery.
which year was it like when was
That was the microscope came into the field probably around 1970s, 1970s, 1980s, and by Dr. Ghazi Yasser Ghili is called the father of modern neurosurgery because of this microneurosurgery. With this invention, we used to do lot of micro neurosurgical procedures.
okay.
I mean, totally differently than how it was done before. So today, the neurosurgery that we have microscope, we have endoscope, we have other very advanced technologies in neuromonitoring, everything with one goal, to preserve the function of the patient. So basically, it has increased the safety and the precision in the surgery. So that's why neurosurgery today is extremely safe when we have all the technologies available. It's done by the expert neurosurgeon. Definitely, there is no second thought to it.
Okay.
And future, yes,
Yeah.
one very interesting insight into this. We all know that we have a lot of robotics integration, artificial intelligence integration into
Yes.
everything probably. So it's booming in every country in India. So in neurosurgery as well, so we have usage of robotics in spine and brain surgeries, not very aggressively like the GI surgeons are doing for the GI cases, not like that, but we have robotics integration, artificial intelligence integration into basically to know about the planning for the surgery, further precision for the neurosurgical procedures, to give extra added safety. So
Okay.
coming 10 years, definitely I think neurosurgeons will accept those integrations, robotics or whatever, micro neurosurgery, endo neurosurgery more aggressively, more often, and for probably for all the cases. So that is one thing that I see.
Okay, like as you said earlier, brain surgery. Now, like we are using endoscope with it. So, can you like give us some idea about its usage and what about its merits and demerits?
Okay, so before telling about endoscope, briefly I would mention the thing about the
Yeah,
microscope.
surely.
The main purpose is to do the surgery, to see the surgical field very clearly with magnified view. Okay, one expert driver can drive only if he or she can see the road very clearly. Okay,
Yes.
so the same thing happens with the microscope. It gives immense amount of magnification and clarity. One millimeter of blood vessel can be magnified 10 times or 20 times, even 30 times with the microscope. So whatever was not possible before 15 years ago, 20 years ago, today you can do all those surgeries with high precision. Now, where is the endoscope then? Endoscope comes into the picture again for clarity and for vision, but with a different purpose. For example, there is a deep-seated pathology in the brain, that is, for example, a brain tumor in the deep part of the brain, or we need to do one particular surgery in the deep part of the brain, where if we use the microscope, we have to open a larger area of the brain, skin, bone,
Right.
everywhere.
Right.
But with the endoscope, what we can do is we can open less
Yeah.
amount of skin, bone, and the brain as well. For example, 2 centimeter or 3 centimeter of area. With that, we can insert an endoscope targeting that particular area where the tumor is, or where we have to do the surgery. Endoscope goes inside that part, okay, and exactly we can see that part that we want to see, our target area, not disturbing the normal areas, the surrounding. So there it comes, the usefulness of the endoscope. We have 0 degree, 30 degree, 45 degree endoscopes. The idea is microscope gives us a clear straight picture. Okay, endoscope gives us angulated picture as well. For example, if I insert the endoscope in this angle, I can see something whatever is not here but in the surrounding area,
Okay.
but I can perform the surgery. So this is the principle of minimally invasive neurosurgery today. So that is a very advanced or thing that we have. We are still evolving. The main use of endoscope we have most commonly done is for the pituitary tumors through the nose. We put the endoscope inside the brain and we remove
Yes.
the tumor. Then, of course, certain pediatric neurosurgeries, hydrocephalosis, we do endoscopic third ventriculostomy, certain usages are there. Again, of course, we have as an adjunct. For example, we perform a surgery with a microscope. Okay, clearly we are kind of 95% sure that all the tumor has come out, but I want to be 100% sure. Okay, by visualizing these corners that microscope cannot show me. So I put an endoscope inside that. It exactly shows me the 30 degree, 45 degree angle, if there is any tumor left behind or not. So there it comes an adjunct to the microscope. Put together microscope plus endoscope, it gives us 100% visualization in the surgical field.
Very well said, sir.
Thank you.
It was very understandable. With that, as we have already spoke about the brain part, Now let's come to the spine surgery.
Sure.
We, as a patient, as a common people, let's say when a patient comes and when the patient understands, okay, now I need to do a spine surgery, I have to go through the knife. So now the patient family or the patient, they might think it's too risky, it's too dangerous, it's too complicated. Let's do one thing, eat painkillers. Beyond that, we have to die more or less. So, like as a surgeon, how would you guide the patient, sir?
It's a very important question that you have asked actually.
Yeah.
Uh, in day-to-day practice, we see that exactly with the same complaint, same explanation, patient come to us.
Right.
They know that they have to undergo a surgery, or somebody has told probably positive or negative about that particular surgery, but they are not sure. They are scared of doing. You know, the reason is, yes, there was a time when, as I told, 15 years or 20 years ago, it used to be with high complication rates because of the same thing. We did not have that much advanced microscope or endoscope, the instruments even. Infection rates were on the higher side, the overall complications were on the higher side. But today, we have all those microscopes, endoscope, other tools available with us. So the difference is, uh, we do the surgery, we know where is the problem, okay, and this patient is coming to us with that particular problem, knowing that they have to undergo the surgery, but somehow they are taking the painkillers, all the medications given by other doctors, accepting the life as a burden or with the pain. So my principle in life is very simple, that if somebody is living, he or she should live 100%.
Yes.
There is no substandard living. So there is no living with pain. That living should be pain free. There is no compromise to life. There is only one life, okay. And today I can 100% confidently say that with a proper microsurgery or a micro plus endoscopic spine surgery, the patient can be 100% cured with very good outcome and high satisfaction that we see today. They are continuing with the regular activities, aggressive activities, even jogging, jumping, playing sports, everything they can continue, provided that it's done by an expert, and expert neurosurgeon, spine surgeon. It's done properly when it is actually indicated. Yes, one thing I would say, there are conditions where patients have some amount of back pain or
Yeah.
nerve related pain, where we see spine problems, but it is not exactly indicated for surgery. That means the problem is not much at that point of time, and we consider medication and physiotherapy and other mode of treatment for that. Only when it has come to the that beyond this borderline where it requires surgery, perform the surgery, there is benefit balance we have to go to. So that is the way to look at it, I believe.
Surely. What is sleep disc? Like, if you could brief us out about and how, like, as a patient who is coming with a nominal pain, how to cure that problem which can be causing the severe causes of sleep disc.
See, disc is the structure that is in between the two spine bones. The
Okay.
bones are called vertebral bodies. In
Yeah.
between the bones, we have the intervertebral disc. We all know as a disc. Now, the function of the disc is to absorb the shock. Whenever we are walking, there is a bumpy road, and any kind of movement, it absorbs the shock in great amount. Axial load it takes. So, with age, with other kind of degeneration, what happens? Somehow it starts degenerating. The water inside the disc, that is exactly around 80 to 85%, that is responsible to absorb the shock. So the soft part of the disc comes out. And why it happens? The outer part of the disc becomes softer, okay. So gradually there is a hole and the disc comes out through it. We call it slip disc. Now what happens with that? Just behind the disc we have very important structure. We call it spinal cord or the nerve roots. The same nerve is going to your legs and foot and hands, necks, everywhere. So whenever the slip disc happen, the disc is coming behind and it is compressing the nerve root. So what will happen? You will have nerve related symptoms.
Yes.
Tingle, it starts with the tingling, numbness, then it becomes pain. Long lasting pain becomes a chronic pain, Okay, it also generates back pain to start with. So different kinds of back pain, leg pain, radiating pain, sciatica, this is all primarily because of the slip disc. It is just the starting beginning
Okay.
of it. So what happens when the slip disc happens, disc has come out, that means the spine is not able to take the load. So the just behind that there are joints and bones and the ligaments that increases in size, it causes further compression. Okay, when this thing happen, it requires a surgery.
Okay.
Only a simple slip disc sometimes can be managed with medication or physiotherapy, but yes, because there are important structures, it has very crucial consequences, so we need to manage it quite aggressively.
So my next question to you would be कि अभी तो बहुत सारे इंफॉर्मेशंस इंटरनेट में मिलते हैं which might be wrong, which might be right. क्या वैसे मिसकंसेप्शंस है न्यूरोसर्जन्स एंड न्यूरोसर्जरी के बारे में जो आप हमें थ्रू आवर पॉडकास्ट आप शेयर करना चाहते हैं?
तो पहला मिसकॉन्सेप्शन एग्जैक्टली वही बोलूँगा आउटकम को लेके, कि न्यूरोसर्जरी अगर किसी को हुआ तो पेशेंट शायद बिस्तर से नहीं उठेगा, इसका आउटकम अच्छा नहीं होगा. सो दिस इज द फर्स्ट मिसकॉन्सेप्शन दैट आई यूजुअली नोटिस. तो एग्जैक्टली ऐसा नहीं होते हैं. तो इसमें भी हम दो डिवीजन कर सकते हैं. वन इज़ द इमरजेंसी केस, अनदर इज़ द इलेक्टिव केस. इमरजेंसी में डेफिनेटली हमारे पास स्ट्रोक्स या हेड इंजरीज ऐसे आते हैं. तो हर तरह का पेशेंट मिलते हैं जो माइल्ड हेड इंजरी रहते हैं या माइल्ड स्ट्रोक रहते हैं, या तो जिसका माइल्ड या मॉडरेट सीवियर हेड इंजरी रहते हैं, स्ट्रोक रहते हैं. तो इनमें से जिसको भी हमको ऐसा लगता है कि इमीडिएटली सर्जरी करने का ज़रूरत है और सर्जरी करके एक पॉजिटिव आउटकम भी मिलेगा, वी डू द सर्जरी इमीडिएटली विदाउट एनी डिले. तो उसमें देन अगेन आफ्टर दैट शॉर्ट टर्म ऑफ आईसीयू स्टे, वेंटिलेशन, अदर मेडिकल मैनेजमेंट इज़ कॉमन. उसके बाद हम देखते हैं दैट पेशेंट इम्प्रूव्स ग्रेजुअली, इट टेक्स टाइम. अचानक से वो ठीक नहीं होते हैं. उन लोग 1 महीना, 2 महीना, 3 महीना, 4 महीना ऐसा टाइम लगता है. बहुत ही धीरे, 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 धीरे स्लो इम्प्रूवमेंट उनको होते हैं. कुछ पेशेंट्स ऐसे भी हैं जो सिस्टमिकली हाई रिस्क, मतलब उनका ब्रेन के साथ-साथ लिवर का, किडनी का, हार्ट का, लंग का मल्टीपल प्रॉब्लम हो सकते हैं. तो सब मिला के एक हाई इन्फेक्शन चांसेस, लो इम्यूनिटी जो होते हैं, सब मिला के एक सिस्टमिक हाई रिस्क फैक्टर क्रिएट होता है. वो पेशेंट में इम्प्रूवमेंट काफ़ी स्लो होते हैं, या तो किसी भी वक्त इन्फेक्शन की वजह से, किसी भी और सिस्टमिक वजह की वजह से ये लाइफ रिस्क भी हो सकते हैं. इन जनरल ऑन एन एवरेज अगर मैं बोलूँ तो डेफिनेटली हम न्यूरोसर्जरी इमरजेंसीज में करके काफ़ी अच्छा आउटकम दे सकते हैं, लेकिन उसमें पेशेंस चाहिए और उसमें टाइम चाहिए. जो माइल्ड इंजरीज होते हैं या तो कुछ ऐसा सिचुएशन होते हैं जिसमें हम अभी सर्जरी करेंगे तो मतलब 3-4 दिन में इम्प्रूवमेंट आ जाएगा, कुछ होते हैं. सो इट हैपेंस विथ सम अमाउंट ऑफ सम काइंड्स ऑफ स्ट्रोक और काइंड्स ऑफ द हेड इंजरी, बट इट इज़ पॉसिबल. अगर मैं इलेक्टिव सर्जरीज का बात करूँ तो उसका आउटकम बहुत ही अच्छा है आज तो. ओके, क्योंकि अगेन जो मैं बोल रहा था कि वी हैव माइक्रोस्कोप्स, एंडोस्कोप्स एंड एवरीथिंग, ऑल द अदर टूल्स.
Yes.
So we can plan the surgery. We have time to plan the surgery as I want. Okay, so then we do the surgery and we have the strong team to follow up and see for the medical part of the patient's problem and other things. So we can actually provide a very good outcome for the elective cases. Yeah.
श्योरली. अच्छा तो देखिए बहुत सारे एक्सीडेंटल केसेस आते हैं वेयर द पेशेंट लाइक इट्स इन अ सीवियर कंडीशन. उनके बचने का चांसेस रेट कैसा होता है? लाइक एज अ सर्जन अब जब पेशेंट को देखते हैं एट अ फर्स्ट ग्लांस इन इमरजेंसी, लाइक हाउ डू यू विजुअलाइज इट?
सो कुछ साइंस होते हैं. बेसिकली अगर हमको क्लिनिकली ऐसा देखे कि आँखों का रेस्पॉन्स ठीक है, या तो हमारा न्यूरोलॉजिकल्स कुछ रेस्पॉन्स रहते हैं, उसके ग्रेडिंग के हिसाब से ये बहुत ख़राब नहीं है, तो डेफिनेटली उनका बचने का चांसेस और पोस्ट सर्जिकल इम्प्रूवमेंट का चांसेस काफ़ी ज़्यादा है. लेकिन कुछ कुछ पेशेंट्स ऐसे होते हैं जो आँखों का रेस्पॉन्स नहीं रहते हैं, या तो न्यूरोलॉजिकली मिनिमल रेस्पॉन्स ना के बराबर ही है. हाँ, तो सो उन पेशेंट्स में क्या होता है बेसिकली, वो पेशेंट ब्रेन डेड की तरफ जाते रहते हैं बहुत ही जल्दी. उनमें बचने का चांसेस ना के बराबर या तो बहुत ही कम रहते हैं. अगर ये एल्डरली पेशेंट है तो और भी ख़राब. अगर यंग पेशेंट है तो हम पूरा कोशिश करते हैं जितना भी मिनिमम साइन हो उसको रेस्पेक्ट करते हुए सर्जरी के लिए जाएं, और पूरा हमारा 100% कोशिश रहे जितना भी पॉसिबल हो तो उसके लिए करें. बाकी जो होते हैं दैट जस्ट विद द टाइम वी हैव टू सी.
श्योरली. Thank you.
Thank
With that, next question that I would be asking you, and which I have heard like not very few times, it's very common कि ब्रेन बाईपास सर्जरी हम लोगों ने सभी सुना है हार्ट बाईपास सर्जरी अब ये ब्रेन बाईपास सर्जरी क्या होती है
Well, this question is quite, favorite to me. So I have particularly, good experience in assisting or doing the brain bypass surgeries, and I can answer that well, I think. So what happens in heart bypass or any other bypass? Basically, we are bypassing two things. Any bypass road is bypassing one high traffic area and connecting these two separate point A to point B. The same thing happens in bypass and brain bypass also. Like in traffic, when there is a high traffic or the traffic area is not functioning well, then we do the bypass. We consider about the bypass. Same for the brain. When there is a stroke, milder amount of stroke, when particular artery supplying that area is significantly narrowed down, okay, it's becoming so thin that there is hardly any blood supply, and it is causing repeatedly strokes, mini strokes. Okay, in that cases, what we do, we connect one artery from outside the brain. Okay, and we take the artery and we connect it inside the brain with one of the surface arteries. For example, there is an artery A that is not functioning, that is not supplying properly, and artery A has multiple branches that is supplying different parts of the brain. We take the artery from outside of the brain and you connect it one or multiple branches. So this is what the bypass is. Now in this bypass, most commonly done is STA MCA bypass. We take the artery from superficial temporal artery and connect it to the middle cerebral artery. This is called direct bypass. Okay, so immediately there is an revascularization. We establish the vascularization. Now there is another form of bypass, we call it indirect bypass. That means we don't directly connect the artery with this brain's artery, the outside artery along with the muscles and the soft tissue, we take it and put it on the brain surface, so that gradually over a period of time, coming weeks or a month, so the brain starts getting the blood supply from the outside arteries. We call it indirect bypass. So in majority of the cases what we see in India these days, you will be amazed to know that majority of them are kids, children.
okay
Okay, stroke.
what's the age group
Yeah, no, doesn't matter, it can be from 5 years to 10 years or 15 years.
okay
Okay, the most common age groups, we call it moya disease, where one of the major arteries get narrowed, one side or the both side, then we do the bypasses. Now the moya disease can happen in young adults or even adults also. Okay, the usual symptom is strokes, repeated amount strokes. Okay, with the speech difficulty, seizures, hand weakness, leg weakness, multiple fall in school, and all those things. So we do the bypass and the outcome is great. Okay,
okay so
so
what's the recovery rate of this surgery
recovery is like any other surgeries.
okay
Okay, so surgical wound healing, surgical period we need to take care. And what happens before the surgery, if the child wants to aggressively work or play or do something, that means the brain needs extra amount of blood or oxygen.
Hmm.
Because there is problem with the artery, brain is not getting that much blood or oxygen. So with the bypass we are re-establishing the circulation and the brain starts getting the enough oxygen or the blood. So with period of time, 1 month 2 month period, we don't see those symptoms that used to happen before. So apart from that, I don't think there is anything else regarding the recovery of the surgery. It's great.
surely lastly I would ask this question to you see patient family common people we tend to visit South India for our uh, medical facilities we want to visit South India to get what we want we don't believe in Kolkata's infrastructure why is it so why do patient does not wants to consult in India like in Kolkata basically and also where it correlates the correlation of the costing is quite same
Well, the question is quite interesting. Well, I was in Bangalore for probably 7 to 8 years, and now I'm a practicing consultant neurosurgeon in Kolkata. So I think I can answer this question bit. So I believe there are basically three factors into it. First is the perception of the cities or the facilities of the cities among people. because it again depends on the job opportunities and the technological advancements in the cities and socioeconomic factors. Then another very important factor, I believe, is the branding. South India's hospitals or the institutes starting branding themselves very strongly quite long ahead. Okay, long ago. So both digitally and offline, or what sort of branding, not for India, not for locally, but for international aspects also. So
Right.
gradually they started attracting patients or people from all over the country and outside the country. It happened. Now another thing that now I believe is the very early implementation or early evolution of multidisciplinary treatment or the care or the institutions. Like, if you go to any of the places, you will see there are institutions practicing as a multidisciplinary institutions where everything you can get under one roof.
Yeah.
And then they are branding that particular thing along with the doctors, so people get to know this. It becomes comfortable for the patients as well. Now the cost factor is definitely comparable here. Kolkata, even we have better prices here. Now I mentioned about all the facilities, hi-fi things about surgery that they started quite long ago and all those things. That doesn't mean that we lack in quality and all. Even Kolkata has very good number of very excellent surgeons in our cities. But I feel we need to focus more and more on our national presence, international presence in terms of branding, connecting with people, patient education, and very importantly, to showcase our skill to the world. Sharing the patient's experience, testimonials, and all those things actually matter, because this is the only way when people get to know the hospital or the doctor. Yeah,
Surely. Thank you. And it was lovely connecting with you. And
thank
it
you.
was my pleasure to meet you, sir. Thank you so
It was
much.
nice conversation with you. I hope I could justify this, and thank you very much for inviting me.
Thank you, sir.
Thank you.
Thank you everyone for watching this video. Do comment. We would love to read your messages. Also, we would further be coming with insightful videos to make you understand more about the healthcare facilities, breaking myths and empowering knowledge. Thank you.